Have you started hematology? So you've had microcytic anemia. Now, can you tell me what is macrocytic anemia? Chromia, what will be the hemoglobin concentration in such RBCs? LHMC, এটা একটা নেমোনিক, লেডি হার্ডিঞ্জ মেডিকেল কলেজ, LHMC, পেলাম না তো কেউ ওটাতে, নেমোনিকটা মনে রাখি, ঠিক আছে? লিভার ডিজিজ, hypothyroidism, megaloblastic anemia, which is caused by vitamin B12 folate deficiency. What are its clinical features? Clinical features of megaloblastic anemia, macrocytic anemia. Anemia clinical feature? And weakness, pallor. The other special features of megaloblastic anemia is neurological deficit. Special. How can you diagnose it? And পরীক্ষাতেও এটাই হবে, তুমি যতই বলো টিচার কিন্তু অ্যান্ড করে মাথা খারাপ করে দেয়। Okay, how is it treated? So, what is anemia? I will give you a brief introduction. What is anemia? It is the reduction of the total red cell mass below normal limits. That is, bas, RBC কমে গেল, anemia হলো. So, we can classify anemia morphological classification and pathophysiologic classification. Morphologic classification, there is microcytic hypochromic, normocytic normochromic, macrocytic normochromic. Microcytic hypochromic is iron deficiency anemia. Apart from that, thalassemia, anemia of chronic disease. Normocytic normochromic, usually aplastic anemia, hemolytic anemia. And macrocytic normochromic is megaloblastic anemia. And pathophysiologic classification, anemia due to increased blood loss. That would be hemolytic anemia. Anemia due to decreased red cell production, that is what we are dealing with today, that is decreased red cell production. And anemia due to increased red cell destruction, that is again hemolytic anemia. Okay, pathophysiology ke এটা তো বললাম. Can you see this actually? Okay, I'll just say. Inherited genetic defects. Decreased red cell production can be inherited genetic defects like Fanconi's anemia. That is a cause of decreased red cell production. I cannot help that now. So I'm reading it aloud. Please listen. Increased genetic defect is Fanconi's anemia. Nutritional deficiency. Nutritional deficiency that can be due to deficient DNA production or defect in hemoglobin synthesis. Due to defect in DNA synthesis, that will be macrocytic anemia, megaloblastic anemia due to vitamin B12 folate. They help in DNA production of all cells, not just bone marrow cells, all cells. But bone marrow cells are rapidly dividing, so the defect in their DNA synthesis manifests first. Apart from that, hemoglobin synthesis, that would be iron deficiency anemia. Apart from that, there can be erythropoietin deficiency, that would be renal disease, chronic renal failure, immune-mediated injury of progenitors. If there is immune-mediated injury of progenitors, that leads to aplastic anemia. Bone marrow is failing to produce the blood cells, which is causing the anemia. Apart from that, there can be inflammation mediated iron, anyway, inflammation mediated iron sequestration. That would be anemia of chronic disease. Any kind of chronic disease like tuberculosis that can lead to anemia, which causes inflammation. Primary hematopoietic neoplasm. Primary hematopoietic neoplasm would be the neoplasms that are arising in the bone marrow. Any leukemia will give rise to anemia. When we have to diagnose leukemia, we always see not just that high WBC count is there. We always will see if whether or not anemia is present, whether or not thrombocytopenia is present. Any kind of leukemia will always give rise to anemia. Space occupying marrow lesions. Space occupying marrow lesions, one is if there are any metastasis in the bone marrow, that will not let the blood cells grow within the marrow. Any metastasis or any granulomatous disease like tuberculosis, that can give rise to anemia in this way also. Apart from that, infections of red cell progenitors, that is parvovirus B19 infection that affects directly the bone marrow cells and causes anemia. And then there's unknown mechanisms. Now, megaloblastic anemia. Now, the previous chart, this chart I have taken from Robbins. Please go through it. All the causes that I said, they are given in details. Megaloblastic anemia, that is caused by decreased red cell production due to impairment of DNA synthesis. I have already explained why vitamin B12 and folate both are required for DNA synthesis. They are deficient, DNA synthesis is impaired, RBCs are not getting the DNA, they cannot manufacture the DNA, and there is anemia. Leads to ineffective hematopoiesis and morphologic changes of RBC lineage. Now, this morphologic changes, do you know how the earlier progenitors of the RBC cell lineage, can you name them? Early normoblast, intermediate normoblast, late normoblast, reticulocyte, RBC. So what happens is the DNA maturation lags behind because DNA synthesis is impaired. So DNA maturation lags behind, but the hemoglobinization of the cytoplasm continues. So there is ineffective erythropoiesis and nuclear cytoplasmic asynchrony. That means the nucleus is lagging behind and the cytoplasm is maturing as it is supposed to. So there is nuclear cytoplasmic asynchrony. They are not synchronized, which can be easily diagnosed if we look at the bone marrow cells. You will be amazed that the clinicians who pass out will send bone marrow to the pathologist, which is a very painful procedure for the patient. Very, very painful. We have to pierce the bone. It is very painful. Haddi bhenge bhetor theke we have to collect the marrow. Yet the clinician who have passed out and not listened to the pathology class when they were supposed to, so what they do is without doing the vitamin assay, they will send bone marrow requisition. So don't do that, please. Please understand that vitamin assays are very important. If a patient is presenting with anemia, especially macrocytic anemia, don't just go looking for neoplasm and leukemia. Okay, the other thing is abnormally large erythroid precursors and red cells. So what happens is that, as I told you, that the maturation of cytoplasm goes on, but the maturation of nucleus lags behind, and the RBCs, they turn out abnormally large, which is also evident in the peripheral blood smear. And the electronic counters, they are very effective. Nobody actually measures RBCs in the Newbert chamber, and nobody looks at all that. What we do is we go through the report of the electronic counter. Electronic counter gives us the MCV, MCH, all this. We look at that and we can easily, it is very good, very effective in diagnosing macrocytosis in the blood. Now, causes of megaloblastic anemia. That is vitamin B12 deficiency, folic acid deficiency, and then there can be unresponsive to vitamin B12 or folic acid therapy. Now, vitamin B12 deficiency, it can be due to decreased intake and impaired absorption. Now, what we need to remember is that the vitamin B12 stores in the body, the hepatic stores of vitamin B12, are usually enough for 3 to 5 years. So a person needs to not intake any vitamin B12 for about 3 to 5 years to actually present with the nutritional deficiency. So mostly if the macrocytic anemia is caused by vitamin B12 deficiency, it is due to impaired absorption. Impaired absorption means intrinsic factor of Castle comes into play. Intrinsic factor of Castle. Do you know which cells or which organ manufactures the intrinsic factor? Yes, parietal cells. So if the patient has undergone gastrectomy or the patient has atrophic gastritis, in these cases, the stomach fails to manufacture the intrinsic factor, and this gives rise to impaired absorption of vitamin B12 and anemia. And then there can be folic acid deficiency. Now, the folic acid requirement in the body stores for the folic acid are for about enough for about 3 to 4 months. So we need to continue the intake of folic acid to not present with folic acid deficient macrocytic anemia. This is also very important in pregnant women, as we know. We all know that. Folic acid deficiency can also give rise to neural tube defects in the fetus. So it is recommended that person start intake of folic acid even before she gets pregnant, so that the requirement of folic acid for the proper development of the neural tube of the fetus is not hampered. Eglo সব MCQ for PG. Okay, so the decreased intake causes folic acid deficiency. For folic acid, decreased intake is the more important cause than impaired absorption. Impaired absorption, of course, can lead to folic acid deficiency. Now, this absorption takes place in the intestine. So, if there is any malabsorption syndrome, can you name any malabsorption syndromes of the intestine? Celiac disease, have you heard? So many, like we get all this food these days which says gluten free. Gluten free. Why? People don't understand whether or not they have celiac disease. They start taking a gluten free diet. What happens is gluten sensitive celiac disease is also called gluten sensitive enteropathy. Gluten or gliadin cannot be absorbed by their special defects in the intestinal cells, and so this leads to malabsorption syndrome. That is celiac disease. Apart from that, there is tropical sprue. Tropical sprue is caused by uh, Topherima whipplei, that is the bacteria that causes tropical sprue. Apart from that, intestinal infections by some E. coli, enterotoxigenic E. coli, that can lead to malabsorption. Apart from that, in Scandinavian population or Russians, there is a special parasite, a fish tapeworm, Diphyllobotrium latum, D. latum, that can cause malabsorption. So these are the causes of impaired absorption. It applies to both vitamin B12 and folic acid, but as I said, folic acid deficiency presents first because the stores are very less in the body. Apart from that, increased loss, increased requirement. I've already said increased requirement in growing children, pregnant women. They can present with folic acid deficiency and impaired utilization. If there is any enzyme defect, then there can be impaired utilization. I'll go through this later, what is called unresponsive to vitamin B12 or folic acid therapy. So the PBS findings in macrocytic anemia. Now these are the normal RBCs. there is this slight central pallor. If this is increased and the size of RBC is low, it becomes, if the central pallor size increases and the size of RBC decreases, what is it called? Yes, microcytic hypochromic. How do you know? How will you know in the peripheral blood? The size is less. Small lymphocyte, yes. So now this is macrocytic. See, the central pallor is decreased. There is almost no central pallor, and the RBCs have increased in size. So that is macrocytic normochromic or macrocytic hyperchromic. And we can also get oval RBCs. So it can be macro-ovalocytes. There is lack of central pallor, but MCH is not elevated. There can be, in severe deficiency, there can be anisocytosis, folliculocytosis. What is meant by anisocytosis? Variation in size is anisocytosis. And what is variation in shape? Folliculocytosis. Okay. The other features are basophilic stippling, Cabot ring, Havel-Jolly bodies. Now, so this is basophilic stippling. This is an RBC. Here we will get these small, actually these are supposed to be blue. Small bluish dots we will be able to see in the RBCs. That is basophilic stippling. Any other cause of basophilic stippling? Lead poisoning. This is Cabot ring. In the RBC, this kind of ring will be visible. This is usually seen in bone marrow rather than the peripheral blood. And these are Havel-Jolly bodies. These are bluish and slightly larger and not as many as these small dots. These are Havel-Jolly bodies. Okay, apart from that, reticulocyte count will be low. Why? Why will the reticulocyte count be low? Hmm? RBC production is low. Obviously, reticulocyte count is low. Okay, occasional nucleated red cell progenitors in peripheral blood when anemia is severe. Normally, we don't get the nucleated normoblasts in the peripheral blood. Normally, we don't get nucleated RBCs in the peripheral blood. They may appear if the anemia is severe. And nuclear hypersegmentation in neutrophils. How many lobes are normally seen in the neutrophil? 3 to 5, yes. If there are more than 5 lobes in at least 5% of the RBC seen in the peripheral blood, then we can say that this is hypersegmentation of the neutrophils. Bone marrow findings. The marrow will be hypercellular. Actually, the marrow is trying to manufacture many RBCs, but the RBCs, it is failing to actually produce mature RBCs. So the marrow is usually hypercellular. Megaloblastic changes at all stages of erythroid development. Now, the megaloblastic changes, I don't know if you will be able to appreciate. Just remember that sieve-like chromatin is seen in the RBCs. Normally, the RBC nuclear material is not sieve-like. Sieve-like মানে ছাকনির মতো। Sieve-like chromatin in the all the nucleated erythroid cells. That is megaloblastic change. I've already explained nuclear to cytoplasmic asynchrony. That is, the nuclear maturation is lagging behind. Cytoplasmic maturation is progressing as it is supposed to. So there is nuclear and cytoplasmic asynchrony. Myelocytes and megakaryocytes will also show some changes. Myelocytes, there can be giant metamyelocytes and band forms. These are progenitors of neutrophils, eosinophils, all of them. These are the progenitors, so they can be large in size, giant meta. And large and bizarre megakaryocytes. These are progenitors of platelets. These will also become large and bizarre. Now, vitamin B12 metabolism. What is vitamin B12? It is an organometallic compound known as cobalamin. Now, you have learned vitamin B12 metabolism in biochemistry last year. Okay, the sources are meat, fish, milk, eggs, and less in plant sources. So, this is the new trend now, vegan diet. Pure vegetarians usually don't present with megaloblastic anemia because they still consume milk. People who follow vegan diet, they may present with macrocytic or megaloblastic anemia because they don't even include milk in their diets. So strict vegetarian diet needs supplementation and it is stored in liver sufficient for 3 to 5 years actually. Now, absorption. Now, vitamin B12, what it does is it goes through multiple binders. It is like a person going through multiple people. A person, when I was taking classes in dams, what the teacher had explained is, अगर किसी को पकड़ना है, उसको इस्तेमाल करना है और फिर उसको छोड़ देना है, ये कोई विटामिन B12 से सीखे. I will never forget that. So, this is the vitamin B. This picture is also I have taken from Robbins. The vitamin B12, it is bound to a binding protein. This is the vitamin B12, the blue round thing, blue dot is the vitamin B12. It binds with a binding protein and it is ingested. Now, the salivary gland, it secretes a protein called haptocorin. Now, this saliva and the vitamin B12 goes to the stomach. The stomach has the gastric parietal cells. The parietal cells secrete pepsin and they also secrete intrinsic factor. Now, what this pepsin does is it releases the vitamin B12 from this binding protein. So there we get this free vitamin B12 which now binds with the haptocorin which was secreted from the saliva. It binds in the stomach. Now this travels to the duodenum. This is the C loop of the duodenum. So the haptocorin B12 complex is going to the duodenum. Intrinsic factor secreted by the parietal cells, it is also going to the duodenum. Now in the duodenum, the pancreas, it releases its enzyme. Proteases are released in the C loop of the duodenum and there is splitting of the haptocorin B12 complex. The haptocorin is released and vitamin B12 it traverses to the jejunum. This is the jejunum. Now here the intrinsic factor binds with the vitamin B12. So there is intrinsic factor, vitamin B12 complex. Now this goes and then it is absorbed by the intestinal cells. It is internalized by the intestinal cells and then again within the intestinal cells the vitamin B12 is released, taken up by transcobalamin. It's a transports cobalamin, so it is called transcobalamin. transcobalamin 2. Now this goes to the portal circulation and then it is absorbed by all the cells of the body and also stored in the liver. Have you understood? আবার বলবো? Have you understood? Lots of binders basically. Yes, no, no. Should I go through this again? কি হ্যাঁ না ঘুমাচ্ছে ওখানে বসে বসে। Okay, the vitamin B12 is also called extrinsic factor. Vitamin B12 is bound to a binding protein. Now the first person that it utilizes is the haptocorrin. Haptocorrin is released by the salivary gland, it is traveling, it is actually pursuing the vitamin B12 to the stomach. Now, in the stomach, there are gastric parietal cells. The gastric parietal cells secrete pepsin and they secrete intrinsic factor. The pepsin, so the first person that it was bound to, say, vitamin B12 was bound to the binding protein. Now the pepsin releases the vitamin B12 from the binding protein goes away, vitamin B12 is free. Now the haptocorrin was pursuing the vitamin B12, first met in the mouth but couldn't bind. The haptocorrin is binding with the vitamin B12 in the stomach. The moment this binding protein is released, immediately vitamin B12 is taken up by the haptocorrin. Now the haptocorrin, so it is bound to the haptocorrin, but intrinsic factor can see the vitamin B12. It is pursuing the vitamin B12, goes to the duodenum. In the duodenum, the pancreas releases proteases. Proteases free the vitamin B12 from the haptocorrin, immediately taken up in the jejunum by the intrinsic factor. Intrinsic factor from the jejunum, it is bound and then taken up by the intestinal epithelial cells. These are ciliated intestinal epithelial cells. They internalize the intrinsic factor bound vitamin B12. Then it is released, taken up again by transcobalamin, goes to the portal circulation. From there, it goes to various parts of the body. Okay? Now, clinical features. Pallor, mild icterus, all anemias can present with this. Angular stomatitis, glossitis, this is due to the vitamin deficiency. What is angular stomatitis? Yes. What is glossitis? Yes. Okay, the other feature is homocystinemia. Increased homocysteine in the body is called homocystinemia. This can cause thrombosis. Increased homocysteine in the body can cause thrombosis. Thrombosis, the thrombus can lodge in the small cardiac vessels and it actually gives rise to this cardiovascular risk. So in cases of vitamin B12 and folic acid deficiency due to hyperhomocystinemia, there is increased cardiovascular risk. And severe deficiency causes megaloblastic anemia. Even in mild deficiency, there is increased homocysteine. So another thing is that the assay of serum homocysteine is a very sensitive marker to detect vitamin B12 deficiency. Even before vitamin B12 levels go down, serum homocysteine increases and we can detect megaloblastic anemia. Now, I have told you neurological, the vitamin B12 is also responsible for myelin synthesis. Myelin is required by the spinal cord brain cells. So, in cases of vitamin B12 deficiency, because of decreased myelin synthesis, there will be neurological defects. What neurological defects? There will be peripheral neuropathy. Peripheral neuropathy like paresthesia, numbness. Have you heard of neurobion foot? Have you heard? Many people take neurobion foot. These are vitamins required for nerve regeneration. Very popular. কিছু বুঝতে পারছি না, ইন্টার্নশিপে নিউরোবায়ন ফোর্ট। Okay, subacute combined degeneration of spinal cord. This leads to defect in posterior and lateral columns of the spinal cord. Posterior and lateral columns of the spinal cord are responsible for the vibration sense and the position sense. So, in cases of subacute combined degeneration, there will be ataxia, loss of balance, and loss of vibration sense. This is controlled by the posterior and lateral columns of the spinal cord. And there can be neuropsychiatric changes, including psychosis and dementia. In older people, even without the presence of anemia, there can be psychosis and dementia. So they may present with dementia and not anemia because of vitamin B12 deficiency. And another thing is the neurological defects are not reversible. Once they set in, they set in. We cannot change it. So we have to be very careful regarding these. Now, lab diagnosis. I've already said we will examine the peripheral blood. We will look at the blood counts and the hematocrit and the MCV, MCH, MCHC. Apart from that, we usually don't prefer to do bone marrow because it is very painful for the patient and risk of infection. Any invasive procedure increases the risk of infection for the patient, so we try to avoid doing the bone marrow. So the other things that we have to do is estimation of serum folate, red cell folate. Now, the serum folate changes, the red cell, the red cells throughout their lifespan have the same level of folate. So red cell folate, if decreased, it is an indicator that there is folate deficiency in the body. Apart from that, we will estimate the serum vitamin B12. Now, for these, there are microbiological techniques and techniques using radioisotopes. Nowadays, radioisotopic method is preferred, and there are automated machines which use these radioisotopes to estimate vitamin B12 and folate. The test that was previously done is the FIGLU test, formimmunoglutamate test. In this case, 15 milligram of histidine is given orally and the urinary excretion of FIGLU is measured. You just have to know the name, FIGLU test. Acha, now suppose you are working in a peripheral location where you cannot assay serum folate, red cell folate, vitamin B12, you are unable to assay. But you need to diagnose and you have strong suspicion that this person may be having deficiency of vitamin B12 or folic acid. So what we can do is we can go for a therapeutic trial. What we will do is we will either give this person vitamin B12 or folic acid. If the anemia improves, then this was deficient. First we give, say, folic acid because it can be given orally. Now the anemia improves, then it was folic acid deficiency, go on with the therapy. It does not improve. Then we give vitamin B12 and we see if the anemia improves. If it improves, then well and good, it was vitamin B12 deficiency. If it doesn't, we will then definitely have to go for the assays. So in this case, we have to obtain baseline hemoglobin and hematocrit. Patient is given 200 microgram of folate orally or 1 to 2 microgram of vitamin B12 IM every day for 10 days. How do we see that it is responding? We will do the reticulocyte count. Can you tell me the stains for reticulocytes? Supravital stain. New methylene blue, brilliant crescile blue. You cannot readily see the reticulocytes by normal Leishman-Jeansa staining. You have to apply these supravital stains. So we will go for reticulocytes Reticulocytosis beginning on day 3 and reaching maximum on day 6 or 7 is optimal. But this is a very crude method. Therapeutic trial is a very crude method. It cannot be done in pregnant women or patients of renal failure, etc. So basically, this is not usually preferred. Periphery we cannot measure, go to a higher center assay. That is what is usually done. Now, estimation of vitamin B12, it can be done by methyl malonic acid estimation, homocysteine in serum. This can also give me an indication of whether or not vitamin B12 is low. I have already said the importance of homocysteine. Schilling test. Have you heard of Schilling test? You've done vitamin B12 in biochemistry. You've heard of Schilling test? Okay, you just have to know the name, but I will still explain the Schilling test if you're interested. And then I've already said therapeutic trial. Now, Schilling test. Before starting, basically the Schilling test is very cumbersome and it is usually not preferred by the patients. It is usually not done anymore. But by the Schilling test, we can diagnose whether or not there is any gastric deficiency or there is malabsorption or is it just because of vitamin B12 deficiency. We can measure by Schilling test. What is causing the vitamin B12 deficiency, we can understand. So we have to actually measure the serum vitamin B12 prior to this test. It is a two-part test. Okay. So in part 1, radio labeled vitamin B12 is given orally, and after 2 hours of that, unlabeled vitamin B12 is given IM injection. The IM injection, I have already said there is transcobalamin to transport vitamin B12 throughout the body. It is present in the serum, right? So what this does, the IM injection goes to the blood and it binds the transcobalamin. So this has bound the transcobalamin. Now the radio labeled vitamin B12 can be absorbed. The one which was given orally, it can be absorbed by the intestinal epithelial cells. Now we will ask the person to urinate. This helps in urinary excretion of absorbed radio-labeled vitamin B12. The urinary radio-labeled vitamin B12 is then assayed. In 24-hour urine sample, we will measure the radioactivity and more than 7% is considered normal. Now, say we have given oral vitamin B12 and there is more than 7% urinary excretion of vitamin B12. So, then that means that there was vitamin B12 nutritional deficiency. Now, if there is less than 7%, then it can mean either there is intrinsic factor deficiency or small intestinal malabsorption. So then we will go to part 2. If the result of part 1 is normal, then it is stopped. If it is abnormal, then we go to part 2. In part 2, along with the radio-labeled vitamin B12, we will give orally intrinsic factor. If then the entire test will proceed as before in part 1. If the excretion now becomes more than 7%, then it means there was intrinsic factor deficiency. If it still remains abnormal, then it means there is small intestinal malabsorption. Have any of you understood Schilling test? You've not. If you've not, then forget it. Now, have you heard of pernicious anemia? Another name for pernicious anemia? Huh? Addison's anemia? It was actually first diagnosed by Addison. Why is it called pernicious? Do you know the meaning of the word pernicious? Pernicious means something that is gradual and harmful. In previous days, If a person was diagnosed with pernicious anemia, it was invariably fatal. It was invariably fatal. Nowadays, we have isolated vitamin B12 and we can give therapeutically vitamin B12 to a person suffering from pernicious anemia. But previously, it was not there. So, it is called pernicious anemia. In pernicious anemia, what happens is there is atrophic gastritis. It means there are autoantibodies against gastric parietal cells. The gastric parietal cells are destroyed, and so there is no secretion of intrinsic factor. If there is no secretion of intrinsic factor, vitamin B12 is not absorbed. If vitamin B12 is not absorbed, then there is anemia and neurological deficit. So that is pernicious anemia. It was invariably fatal. Nowadays, we can go on giving, if a person is diagnosed with pernicious anemia, we can go on giving them parenteral vitamin B12 or even high doses of oral vitamin B12. If we give a person high dose of oral vitamin B12, at least 1% is absorbed. At least 1% of that is absorbed. So from the mouth only it starts absorbing. So that is a treatment for pernicious anemia. It is no longer fatal. And this is something you should know and you should remember. A person who has any autoimmune disease, it never presents with just one defect. If a person has atrophic gastritis, they may have along with it Hashimoto's thyroiditis, another autoimmune disease, or can have rheumatoid arthritis, or can have SLE, or can have diabetes. Autoimmune diseases like diabetes type 1. Autoimmune diseases usually present with many autoimmune diseases, and there is not usually just one. So, pernicious anemia can be associated with other autoimmune diseases. And in pernicious anemia, there is increased risk of gastric cancer. Now, treatment. Now, megaloblastic anemia should never be treated with folate alone unless vitamin B12 levels are normal. What happens is if you give the patient only folate and vitamin B12 deficiency was already there, then what happens is neurological deficits precipitate. And I've already said neurological deficits are irreversible. So folate therapy alone should never be done. We should always go for the vitamin B12 and folate assay and then start therapy. Like many people may be tempted because folate can be given orally and vitamin B12 is usually given parenterally. So a patient will prefer folic acid kheni, I'll be done, I'll be sorted, but that doesn't happen. He'll present with neurological deficits. Folate, the dose is 1 to 2 milligram of folate orally per day for vitamin B12. First, we have to go for the loading dose and then the maintenance dose. It is 1000 microgram of hydroxycobalamin. It is a synthetic derivative. 1000 microgram of hydroxycobalamin every day for 1 week. After that, maintenance dose of 1000 microgram once in every 3 months. I've already said if large dose of vitamin B12 is given, 1% of it is absorbed. Now treatment effect. What happens after we start therapy? There will be reticulocytosis beginning on day 3 and it reaches peak by the day 6 or day 7 and then normalizes by the 3rd week. So that is, there is adequate response. Once we start therapy, we have to monitor whether or not the person is responding to this therapy. So this reticulocyte count is the easy way. Apart from that, even within 1 week of starting therapy, there is a feeling of well-being. There is a perception of well-being in the patient even within a small time as 24 hours. Even just you give the injection and after 1 day, the patient feels better. Apart from that, erythropoiesis becomes normoblastic. It was megaloblastic previously, it becomes normoblastic. Now, the side effect of this is sudden and severe hypokalemia. Hypokalemia causes arrhythmias. You will learn this in medicine. Hypokalemia rapidly causes arrhythmia and death. like sodium and potassium, they go hand in hand. But sodium deficiency, the body can tolerate sodium deficiency, but body cannot tolerate potassium deficiency. What happens is, if there is severe vitamin B12 or folate deficiency, even the intestinal cells, they become atrophic. Not just the gastric, but even the intestinal cells can become atrophic. And now, once you start therapy, the intestinal cells regenerate. Once they regenerate, they internalize the potassium. If the potassium levels then increase, then it can cause arrhythmia. So once we start therapy, we have to be very careful regarding this side effect. দিলাম ভিটামিন B12, পেশেন্ট মরে গেল, মার খেলাম কে? আমি। Other causes of megaloblastic anemia, this is what I told. Suppose there is not vitamin B12 deficiency or even folate deficiency. The person is not responding to even vitamin B12 or folate. That can be due to some drugs. Drugs like chemotherapeutic drugs, methotrexate, trimethoprim. Apart from that, cytosine arabinose, 5-fluorouracil, 6-mercaptopurine. Apart from that, zidovudine. What is zidovudine? Anti-HIV. Oral contraceptives. What is nitrous oxide? It is an anesthetic. These drugs can also cause macrocytic megaloblastic anemia. Apart from that, hematologic disorders like MDS, myelodysplastic syndrome. This can cause megaloblastic anemia. Erythroleukemia is a kind of leukemia of erythroid cells, erythroblasts actually. These can cause megaloblastic anemia. Apart from that, there can be acute megaloblastic anemia. It rapidly develops and may be fatal. It can be caused by nitrous oxide anesthesia or TPN. TPN means total parenteral nutrition. A person is on only IV nutrition and not getting anything orally. Then that is TPN without any vitamin supplementation. Once you go to any government hospital ward, you will see lots of CVA patients with NS, and the NS may be yellow colored. That is the multivitamin injection which is given into that NS. I used to wonder when I first went into the ward, why is it yellow? Why is the NS yellow? So that's vitamin B12 vitamin supplementation which is given through total parenteral nutrition. So now, can you answer these questions? What is macrocytic anemia? What is macrocytic anemia? যে ঘুমাচ্ছে? Speak up. Nobody. I will then make one of you stand up and answer the question. Yes. What are its causes? Please stand up and answer. Hypothyroidism, chronic alcoholism. Clinical features. Clinical features of megaloblastic anemia. Apart from that, and ওটা বলেছে neurological deficit. How do you diagnose it? And so basically, I have done a 1-hour class. I have gone through all of this, and whatever answer you were giving to me at the beginning of the class, same answer you are giving to me at the end of the class. Okay, from now on, I will come, I will teach myself, I will go away. I will not ask any questions. Assay, vitamin assay. How is it treated? Supplementation. Thank you.
Discuss about general anesthetics. We already discussed about local anesthetics. Now, today we will discuss about general anesthetics. So, what is general anesthetics? এটা পরেরটা যাবে না আমার এটা নেই নাকি it is reversible it is reversible. First important thing is it is reversible one. Reversible loss of consciousness, loss of all sensations, especially pain sensation, loss of consciousness, amnesia. Amnesia means loss of memory during the operative procedure, loss of ability to movement, immobility, muscle relaxation, along with abolition of reflexes. So, fourth thing, loss of sensation, loss of consciousness, loss of reflexes, loss of or amnesia, loss of and immobility with muscle relaxation. All these with a reversible one. All these things with reversible one is called general anesthetics. What is the difference between local anesthetics and general anesthetics? Primarily, the consciousness is maintained in case of local anesthesia. There is no amnesia, there is no loss of reflexes, but only the common thing is loss of sensation, especially pain, both for local and general anesthetics. So, what are the principles? The consciousness, unconsciousness, or loss of consciousness is due to the action. Action is rash, reticular activating system, as well as thalamus. The action on thalamus or rash causes unconsciousness. Amnesia, loss of memory due to the action in the cortex and hippocampus. Thirdly, immobility due to the action in the spinal cord. So, anatomical position where the general anesthetic acts in the CNS, different portion of CNS affecting different action. The immobility due to action in the spinal cord. The amnesia due to action in the cortex as well as hippocampus. And unconsciousness due to action in the rash as well as thalamus. Clear anatomical position where the drug acts. Next, the channel which are involved or receptors. These receptors are ion channels. It is not the voltage gated, it is ligand gated ion channels are primarily in action for general anesthetics. General anesthetics acts on the ligand gated ion channels. So what are the ion channels? First one and most important one, GABA A. GABA A is a excitatory or inhibitory. GABA A is a inhibitory, glycine is a inhibitory. So all these drugs acts in the GABA A and glycine, and there is opening of chloride channel, and there is a hyperpolarization. So there is a depression. So activation of GABA A, activation of glycine. This is the activation. Then nicotinic cholinergic receptor blockage. It is a excitatory. So excitatory টাকে ব্লক করে আর ইনহিবিটরিটাকে প্রমোট করে। তাহলে অ্যাকশন অন GABA A, glycine, it activates GABA A and glycine, and they increase chloride conduction, hyperpolarization. Secondly, they inhibit the excitatory like nicotinic cholinergic as well as NMDA, excitatory NMDA. The NMDA, AMPA kinase, 3 type of amino receptors. Here NMDA glutamate type of receptors, they are blocked. So this is a excitatory. 2 inhibitory GABA A and glycine are stimulated, increase chloride conduction, whereas excitatory neurotransmitters are in the CNS are cholinergic one, nicotinic type of cholinergic, as well as NMDA. They block this. And there is a neuronal hyperpolarization specifically due to the gaseous or inhalation anesthetics. They can directly hyperpolarize the neuron hyperpolarization due to directly by the inhalation anesthetics. Next, pharmacokinetic. Pharmacokinetic is somewhat different in case of general anesthetics. So, the route of administration of general anesthetics is route of administration of the general anesthetics. Huh? No, not only inhalation. There are 2 types of, one is inhalation, one is intravenous. So, there is intravenous one and inhalation one. This pharmacokinetic one is described the inhalation one. Inhalation, first one is partial pressure of the gas in the inspired gas, anesthetic in the inspired gas. Partial pressure means if the concentration is increases, the partial pressure of the anesthetic will be high in case of in a inspired gas. Number 2, the pulmonary ventilation. If the ventilation increases, what happen? More amount of the anesthetic drug will reach the alveoli. So from the outside, drug goes into the alveoli. There alveoli, there is a exchange from the alveolar. Around the alveolus, there is a capillary, there is a partial pressure changes. So, high concentration present in the alveoli, from there it goes into the capillary, and from the capillary, it goes into the systemic circulation. So, in the capillary, the drug action depends upon the solubility of the drug in the blood and solubility of the drug in the tissues. And last one is the cerebral blood flow. So from the outside, there is this anesthetic gas, partial pressure is important, then ventilation, rate of ventilation and amount of, will decide the amount of drug reaches the alveoli. Then after alveoli reaches the drug in the alveoli, there is a, from the alveolus to the capillary. That is alveolar exchange. After exchange, the blood now comes into the systemic circulation. In the systemic circulation, the action depends upon the binding of this drug or solubility of the drug in the blood, solubility of the drug in the other tissues, and cerebral blood flow. So, this is, although this drug given in inhalation route, the action is local or systemic. Systemic. Why? Because their action, the site of action is, where is the site of action? In which organ these drugs acts? General anesthetics, thalamus and RAS for unconsciousness, for amnesia, cortex and hypothalamus, and spinal cord for the immobility. So all these are, we can say, it acts in the CNS. So drug taken, inhalation, it goes into the lungs. From the lungs, it goes into the systemic circulation. From the systemic circulation, it goes into the site of action. Here the site of action is different parts of the CNS. So for this drug, route of administration, from the route of administration to the site of action, is it required to go into the systemic circulation? Yes or no? If this drug doesn't reaches the systemic circulation, does this drug can act as a general anesthetics? No. So this is an example of inhalation drug that can act systemically. Whereas give another example where the drug given inhalation route, the drug give inhalation route but acts locally. Give an example where the drug gives inhalation route but acts locally. পড়ানো হয়েছে। হ্যাঁ, কি ড্রাগ দেয়, কি ফার্মটা কি দেয়? সালবুটামল, টারবুটালিন, 3 group of drug given for bronchial asthma or COPD. কি ড্রাগ তিনটে গ্রুপের? beta agonist, anticholinergic and inhalation corticosteroid. 3 groups of drug given in inhalation route, but they act locally. For their action, it is not required the drug to reach the systemic circulation. So this is the difference between general anesthetics. It gives inhalationally but acts systemically, whereas bronchodilators, inhalation corticosteroids used in bronchial asthma, they give inhalationally but act locally. Clear এই পর্যন্ত? So not required to remember vividly all the points, but you have to remember at least this thing for the MCQ, that these stages of anesthesia is made by Godel, scientist Godel, and it is due to the ether anesthesia. It can be differ for the other anesthesia. It is demonstrated by the Godel by the ether anesthesia. There are 4 stages. First stage is stage of analgesia. It starts from the when the drug given up to the if there is a loss of consciousness. This is the first stage. It is a stage of analgesia. Next is stage of delirium. The analgesia theke then up to the there is a beginning of regular breathing. This is stage of delirium. Why it is important to remember the stage of delirium? Even in the stage of analgesia, we can do some small surgical procedure, but in stage of delirium, we shouldn't do any surgical procedure. Stage of delirium, stage of analgesia, stage of delirium. Next is surgical anesthesia. Most of the drug done in this third stage. In the third stage, it starts with the spontaneous breathing and ends with the cessation of the stopping of the spontaneous breathing. And they also divide in the 4 plane. First plane, there is stopping of this eye movement. Second plane, there is a loss of reflex, corneal and laryngeal reflex primarily, whereas third, there is a loss of light reflex due to dilatation of the pupil and intercostal paralysis. So first তিনটে হচ্ছে, first one eye movement বন্ধ হয়ে যাবে, next corneal reflex, শুধু চোখটা দিয়ে যদি তুমি ভাবো মুভমেন্ট শেষ, ফার্স্টে আই মুভমেন্ট, তারপরে হচ্ছে কর্নিয়াল রিফ্লেক্স, তারপরে হচ্ছে লাইট রিফ্লেক্স, and fourth one there is a cessation intercostal paralysis, কারণ it is the fourth stage is the stoppage of spontaneous breathing. Most of the surgical procedure done in the third stage. Third stage can divide in the 4 plane. First plane হচ্ছে যখন eye movement stoppage, second one corneal reflex, third one light reflex, and fourth one intercostal muscle paralysis, and last one is medullary paralysis. So there are 4 stages. First one is analgesia. In analgesia, we can do some small surgical procedure. Stage of delirium, we cannot do any surgical procedure in the second stage. Then third stage, most of this surgical procedure done in the third stage. It can be divided in the 4 plane, and fourth stage is medullary paralysis. So MCQs commonly come The, these stages are done by which scientist? By it is dependent upon the which type of anesthesia. It is a ether anesthesia. So it can differ for different type of anesthesia, especially intravenous anesthesia. This stage may not be there. That clearly it is ether anesthesia. Good. There are 4 stages. Among the 4 stages, most of the surgical procedure done in the 3rd stage. 3rd stage has 4 plane, depending upon the stopping of the eye movement, loss of corneal reflex, loss of light reflex, and loss of intercostal muscle movement. Clear? And 4th stage is medullary paralysis. So, in which stage there is no surgery should be done? 2nd stage, stage of delirium. Maybe it, in MCQ they can give don't not like stage 1, stage 2. They can give in the option A is stage of delirium, then medullary paralysis. They can differ like that. So you have to remember stage 2, stage of delirium. There is should not be any surgical procedure. Goodell, ether anesthesia. So if we go for the classification of general anesthetics, we can broadly separate it. It is one is inhalation anesthetics, another one is intravenous or parenteral type of anesthetics, general anesthetics. So in the inhalation, we can again divide into the gas and volatile liquid. Gas and volatile liquid. So nitrous oxide, কি হয় nitrous oxide NO, N2O না NO2? হ্যাঁ N2, N2O শিওর, NO নয়, NO কি? কোথায় ইম্পর্টেন্ট ফার্মাকোলজিতে? হ্যাঁ কি করে? ব্লাড ভেসেল ডাইলেশন কে করায়? অ্যাসিটাইল কোলিন. So this is N2O, nitrous oxide. It is a gas. It is not a volatile liquid. Inhalation anesthetics can be gas and volatile liquid. In the volatile liquid, there are ether, halothane, isoflurane, desflurane, enflurane, sevoflurane. All other than halothane, isoflurane, desflurane, enflurane, sevoflurane is a fluorinated general anesthetics or inhalation anesthetics. And if we go for the intravenous one, we can divide it in the 2 portion. One is fast acting and another one is slower acting. Fast acting are important for what? For induction. For induction of the anesthesia, it is important. The fast acting, thiopental sodium, propofol, etomidate. Thiopental sodium, propofol, etomidate, methoxytone rarely used. These are all inducing agent. So we give some drugs for their early onset for induction. After that, there is a maintenance dose. Maintenance dose can be given by the either by the slow acting intravenous anesthetics or by the gaseous anesthetics or inhalation anesthetics. The slower anesthetics like benzodiazepine, midazolam, diazepam, lorazepam. Then dissociative anesthesia, anesthetic like ketamine. We can give ketamine. It is another name is dissociative anesthesia. Dissociative anesthesia is a MCQ. Which drug causes dissociative anesthesia? Is ketamine. And third one is opioid analgesics. Fentanyl can use as a intravenous slow acting anesthetic, general anesthetics. So this is the classification. One is inhalation, intravenous. Inhalation এর মধ্যে gaseous are volatile liquid, whereas in case of intravenous there is fast acting and slow acting. যে কোনো টাইপের অ্যানালজেসিক টাইপের ইউজ করা হয়, and in case of anesthesia we can use as a maintenance anesthesia. Their action is primary analgesia. So nitrous oxide. Nitrous oxide, it is a colorless, odorless, heavier than air. Next one, it is non-irritating and low potency. But here is the important thing. Here, the most important anesthetic action is it is a good analgesia. It is very little muscle relaxant effect. So it has a very good analgesic effect. Onset is quick and smooth. Recovery is quick and smooth. So all among all these four parameters, there is no amnesia, no muscle relaxation, no loss of reflex or less effect. The only important effect with nitrous oxide is it is a good analgesic. It is a very good analgesic. Here is another thing. Four topics come as a in nitrous oxide. One is diffusional hypoxia. Second gas effect is associated with N2O. What is second gas effect? Second gas effect, as nitrous oxide is less soluble in the blood, we give a high concentration of nitrous oxide. Along with that, 1% of halothane or other fluorinated anesthetics. So it helps to take this second drug, that is halothane, into inside the systemic circulation very easily. It causes rapid anesthesia. Onset of anesthesia will be rapid. With the help of nitrous oxide, we can increase concentration of ether or halothane or other type of anesthetic inside the body. It is called the second gas effect. By help of nitrous oxide, though nitrous oxide is not very potent drug, it helps to carry the other gaseous general anesthetics to go inside the systemic circulation and brain. It is a second gas effect. And when we disconnect the system, what happens, as nitrous oxide is very less soluble in the blood, they come and block or occupy all the alveoli. So what happens, there will be displacement of oxygen from the alveoli that can causes diffusional hypoxia. So two terms we have to remember which is associated with nitrous oxide. One is second gas effect and one is diffusional hypoxia. Clear? Third one is MAC. MAC is 105%. What is MAC? MAC is minimal alveolar concentration. What is minimal alveolar concentration? It is the least concentration of the general anesthetic gas in the alveoli which can produce a surgical incision or doesn't produce any pain during the surgical incision. So if the MAC is high, the drug is less potent or more potent? It is the minimum. It is the if it is MAC is high, drug is less potent. If MAC is low, drug is highly potent. So three terms. One is MAC, minimal alveolar concentration. It is the minimal concentration of the general anesthetics in the alveoli that can stoppage any painful sensation even in the surgical incision. This is the MAC. Next is second gas effect. Second gas effect, due to the less solubility of nitrous oxide, it helps other anesthetics like halothane to reach the systemic circulation as well as site of action in a high concentration. So using this nitrous oxide, we are giving more amount of other inhalation anesthetics for general anesthesia. This is called second gas effect. But after discontinuation, what happens, as it is a less soluble, all this nitrous oxide comes from the blood to the alveoli that replaces the oxygen present in the alveoli that can produce hypoxia. MAC is for all general anesthetics, especially which type of general anesthetics? Minimum alveolar concentration, তার মানে কি alveolar concentration কাদের থাকবে? Inhalation anesthetics এর potency decide করে MAC, আর second gas effect and diffusional hypoxia is a phenomena purely for the nitrous oxide. It increases the sympathetic tone, which counteract the weak direct effect on the heart as well as circulation. So it stimulates the adrenergic effect to counteract the action on the direct effect in the heart. This is nitrous oxide. Primarily, we cannot use or we are not regularly use nitrous oxide as a single general anesthetics. We have given a concentration mixture of 70% of nitrous oxide along with 25 to 30% of oxygen as well as 0.2 to 2% of other inhalation anesthetics. And this nitrous oxide in this case helps to give the other types of inhalation anesthetics in a high dose inside the systemic circulation. So nitrous oxide cannot be used as a single general anesthetic. It is a very potent or very low potent. If MAC is high, it is a very low potent drug. It have no effect in amnesia or muscle relaxant. The primary action of this is it is a very good analgesic. It has a very good analgesic effect, and it is non-irritant, rapid induction and recovery, smooth induction and smooth recovery. Next is ether. Ether, it is a highly volatile liquid. It is a irritant one. So the inflammable and explosive. MCQ came. Which of these general anesthetics are irritable, inflammable, or explosive? It is ether. Then it has a potent anesthetic, a very good analgesia, as well as marked muscle relaxant. তাহলে আমাদের কি কি চারটে পয়েন্ট ছিল জেনারেল অ্যানাস্থেসিয়ার জন্য? ওয়ান ইজ অ্যানালজেসিয়া, তারপরে লস অফ মুভমেন্ট মানে মাসেল রিল্যাক্সেশন। ইট ইজ এ ভেরি গুড মাসেল রিল্যাক্সেন্ট, বাট নাইট্রাস অক্সাইড ইজ নট এ ভেরি গুড মাসেল রিল্যাক্সেন্ট। লস অফ রিফ্লেক্সেস, লস অফ মেমোরিজ। So among these, it is a very good analgesic. Along with it is a very marked muscle relaxant property, ether. But the disadvantage is it is a irritant, it is a explosive, it is easily inflammable. When we give ether, we can reduce the muscle relaxant. We can reduce the muscle relaxant 1/3 of its original dose, because of its own muscle relaxant property. Ether has a own muscle relaxant property, so we have to give less amount of muscle relaxant from the outside when we give ether anesthesia. But why we are not regularly use ether anesthesia? Because it is irritant, because it is inflammable. It can be acts as an explosive. Clear? And recovery is very slow. Induction is prolonged and unpleasant. In case of other nitrous oxide, it is smooth, rapid onset, and recovery is also rapid. For ether, it is unpleasant. Ether is unpleasant. Recovery is slow. It is well maintained due to the reflex stimulation of the sympathetic tone. Do not sensitize heart to the adrenaline. Even in the African countries still it is used because it is cheap, it is easy to handle, especially when the anesthetic is not heavily trained. It can be used by untrained or less trained type of anesthetic. And it can be used an open drop method which is not used nowadays in India. So what is the difference between nitrous oxide and ether? Nitrous oxide is a very good analgesic. Induction and recovery is smooth. It is non-irritant. It has only analgesic effect. It has no muscle relaxant property. Whereas ether has a good muscle relaxant property, good analgesia, but it is induction is slow, irritant, recovery is slow, and it can cause inflammable. It is inflammable and it can act as an explosive. এইটুকুনি মনে থাকবে তো ইথার আর নাইট্রাস অক্সাইডে কোনটার মাসেল রিল্যাক্সেন্ট প্রপার্টি আছে? ইথার, শিওর? ইথার আর নাইট্রাস অক্সাইডের মধ্যে কোনটার মাসেল রিল্যাক্সেন্ট প্রপার্টি আছে? কোনটার অ্যানালজেসিক প্রপার্টি আছে? Both has a very good, which has a smooth induction and recovery. Huh? Nitrous oxide. Which is inflammable or explosive? Ether is inflammable or explosive. ঠিক আছে? Halothane. It is a potent analgesic, anesthetic, good, not a good analgesic and muscle relaxant. But other points of the anesthesia are very good with this halothane. It is a volatile liquid, or sweet odor. It is not odorless. Nitrous oxide is odorless. Nitrous oxide is odorless. Ether is irritating, and it is a very smooth, sweet odor. Halothane is a sweet odor, non-irritant, non-inflammable. Clear? Solubility of the drug is intermediate, induction reasonably quick and pleasant. So induction can be done by halothane, but induction cannot be done by ether. Direct depression in the cardiac muscle due to the calcium concentration. They can cause fall of BP up to 20 to 30 mm of Hg. Heart rate can be reduced. Heart rate can be reduced due to the vagal stimulation, due to the direct effect on the SA node, as well as absence of the baroreceptor reflex activity. That all can causes reflex tachycardia absent. So there is a fall of BP. If there is a fall of BP, there is a reflex tachycardia that can also be inhibited due to the vagal stimulation, due to the direct effect on the SA node, due to the absence of the baroreceptor reflexes. So they have a action on the CVS. Halothane has a negative effect on the CVS. Heart rate less, BP less. Fall of BP may be there when you use the halothane. Huh? হ্যালোথেনে ইউজ করলে দেখা গেছে যে ব্যারোরিসেপ্টরে কাউন্টারঅ্যাক্ট করে, ব্যারোরিসেপ্টরকে স্টিমুলেট হতে দেয় না, সেই জন্যই ডাইরেক্ট এফেক্ট। ঠিক আছে? ডিপ্রেশন অফ দ্য রেসপিরেশন, but it is less important in case of general anesthetics, because in case of general anesthesia we can maintain the respiration by the mechanical ventilation, but it reduces the depress the respiratory center, that can increase carbon dioxide. So but it is in the clinical scenario, as we use mechanical ventilation during the operation, it is not that clinically significant. It increases cerebral blood flow. Ventilatory support with add of oxygen is frequently required because it depresses the respiratory center. Here is another MCQ. Which drug, which anesthetic is preferred in asthmatics? It is halothane because it counteracts the laryngeal and pharyngeal reflexes. Laryngeal and pharyngeal reflexes, as there is a hyperactivity of these reflexes in case of asthmatic patient, it has been seen when we use halothane, it is better maintained in case of bronchial asthma than the other general anesthetic drug. Inhibit uterine contraction. So in case of pregnancy, especially cesarean section, we shouldn't be use it. If there is a inhibition of the uterine contraction, what will happen? What is the clinical significance? Postpartum hemorrhage. Postpartum hemorrhage will be high if we use halothane as a general anesthetic. তাহলে দুটো এমসিকিউ এখান থেকে, একটা হচ্ছে ব্রঙ্কিয়াল অ্যাস্থমা which general anesthetics is preferred and which is avoided in case of labor or a cesarean section, halothane. Now side effects. Urine formulation is less and there is a less GFR and that can lead to acute renal failure. Similarly, it has been seen especially when we use halothane repeatedly, there is chances of hepatitis. So acute renal failure, hepatitis, liver failure, especially when is used repeatedly. When it used repeatedly, there is a hepatic failure or hepatitis. Now, most of these drugs, general anesthetic, inhalation general anesthetics, how they excrete from the body? You have বেরোবে বডি থেকে, যাচ্ছে যে পথে যদি পার্সিয়াল প্রেসার কমিয়ে দিই, কনসেন্ট্রেশন কমিয়ে দিই, তাহলে সেই পথেই বেরিয়ে যাবে। তার মানে থ্রু দ্য লাং, through the exhalation, these drugs can come out. But the example is halothane can be metabolized in the liver by 20%. Malignant hyperthermia. Malignant hyperthermia, especially when it used with a succinylcholine. Succinylcholine is which group of drug? It is কোলিনার্জিক, কোলিন আছে বলে মাসেল রিল্যাক্সার। কি টাইপের মাসেল রিল্যাক্সার? ক টাইপের মাসেল রিল্যাক্সেন্ট আছে? কম্পিটিটিভ, নন কম্পিটিটিভ। কম্পিটিটিভ ইজ D-tubocurarine, non competitive is succinylcholine. Succinylcholine and halothane, if we give simultaneously, there may be a situation called malignant hyperthermia. As the term says, there is a hyperthermia, so there is a increased BP, there is a increased muscle tone, there will be a tremor, and there is a myoglobinuria will be there. In this situation, is due to a calcium receptor, ryanodine receptor. The presence of ryanodine receptor is associated with malignant hyperthermia. তাহলে malignant hyperthermia MCQ কি? Malignant hyperthermia can caused by halothane, can caused by especially when it is used with succinylcholine, it is due to the receptor, due to the association is due to the calcium receptor ryanodine. How we can counteract this? External cooling, sodium bicarbonate infusion, 100% oxygen, and IV dendroline. That is the another MCQ. Which drug is given in case of malignant hyperthermia? It is dendroline. If management of hyperthermia or short note of malignant hyperthermia, কি লিখতে হবে? malignant hyperthermia, causative drug which can cause it, halothane, succinylcholine, especially when both used simultaneously. Mechanism of action due to the calcium channel, ryanodine type of calcium channel. Sign and symptom, there is a high fever, increased muscle pain, increased muscle tone, myoglobinia, all this. Then management, external cooling followed by 100% oxygen, sodium bicarbonate, and specific one is dandrolone. Due to all this disadvantage also, it is used in the developing country because it is cheap, it is non-irritant, non-inflammable, suitable for both children as well as induction as well as maintenance. In adults, it mainly used as a maintenance. The which one cannot be used as an induction among these three drugs, general anesthetics? Deficiency of halothane, because it is a poor analgesic and poor muscle relaxant in comparison to the other anesthetics. Like nitrous oxide, it is a very good analgesic, and in case of ether, it is both very good analgesic as well as muscle relaxant. But it doesn't have a very good analgesic or muscle relaxant. Concomitant use along with nitrous oxide and opioid along with neuromuscular junction blocker. কি নাম neuromuscular blocker এ? Succinylcholine, very good. আর হ্যাঁ botulinum toxin আর হ্যাঁ কোন গ্রুপটা বলো? অ্যাট্রোপিন মাসল রিল্যাক্সেন্ট হিসেবে ইউজ হয়। অ্যান্টি মাস্কারিনিক এফেক্ট কোন কোন রিসেপ্টরের উপর কাজ করে অ্যাট্রোপিন? আলফা, ভেরি গুড। বিটা, ডেল্টা, ডেল্টায় কাজ করে না। মাস্কারিনিক রিসেপ্টরে করে, মাস্কারিনিক রিসেপ্টরে করে, নিকোটিনিক রিসেপ্টরে করে না। অ্যাট্রোপিন কোন গ্রুপের ড্রাগ? অ্যাড্রেনার্জিক সিস্টেম না কোলেনার্জিক সিস্টেম? কোলেনার্জিক সিস্টেম। কোলেনার্জিক সিস্টেমের রিসেপ্টর কি কি? তাহলে আলফা বিটা কিভাবে কাজ করবে? ওটা পেছন থেকে প্রম্পট আসেনি নাকি, না ভুল প্রম্পট করে দিল? আলফা বিটাটা কি পেছন থেকে প্রম্পট হয়েছে না সাইড থেকে?